Tonight, I'll be giving you my top tips on OCT in myopic eyes. All right, so tip number one. When you do an optic disc OCT in myopic eyes, the nerve fiber layer readout is less reliable, and that's due to a number of different factors. So we've got floaters, more floaters in myopes. There is temporal dragging of the nerve fiber layer. There is peripapillary atrophy. There is tilting of the disc, staphyloma, and there's also magnification error. So the nerve fiber layer circle is larger in myopic eyes due to the refractive error. All of these factors can lead to unreliable optic disc OCT. I'll show you some examples. So a floater. So this patient had OCT. If you look just at the thickness map, you might say, oh, there is a thinning of this segment here, the superior segment. But this is actually caused by a floater, a wise ring that you can see here, and a defect in the thickness map visible there. So got to be careful of floaters leading to segmentation error. Now, the other thing about nerve fiber layers in myopes is that they're dragged temporally, causing false thinning superiorly and inferiorly, and false thickening temporally. So if you look over here, this right eye has false thinning inferiorly and false thickening temporally due to the dragging of the nerve fiber layer. This patient is a high myope and has inconsistent and has a series of optic disc OCTs over time, and the optic disc is inconsistently identified due to the staphyloma, due to the tilting of the disc and peripapillary atrophy. So if you look over here, each scan of the same eye or the same disc looks different. And that's because it can't find the actual, if it's having algorithms got difficulty finding the actual edge of the disc and rim. So my next tip is, if you can't use the optic disc nerve fiber layer, what can you do? So the next tip is look at the ganglion cell layer of the macula. And the ganglion cell layer of the macula can actually help you diagnose and monitor optic nerve disease, including glaucoma, MS, stroke, and tumors. And I'll show you some examples. So this is the first case, is a patient with glaucoma. But at the very beginning, in the first visit, fields were normal. Disc OCT has an artifact inferiorly here, which could be most likely cataract, and causing inferior nerve fiber thinning. And you look at that and you go, well, that's probably from that artifact. It's probably artifact, and it may not be true glaucoma. But the GCL map shows some thinning inferiorly. So that gives us a clue that this nerve fiber layer defect may in fact be real. Now, this fast forward more than 10 years later, this patient is well-established glaucoma with a superior arcuate defect, inferior nerve thinning on OCT of the nerve fiber layer, and progression of the ganglion cell layer thinning of in the macula. Next patient had a stroke and has a left hemianopia, which you can see over here. So hemianopia, homonymous hemianopia on the left side. Now, if you did an OCT of the disc, all you see is maybe a little bit of thinning in one segment on the left side. Nothing terribly exciting. But if you look at the ganglion cell layer thickness, there's actually corresponding thinning of the ganglion cell layer. This is temporal to fixation on the right and nasally on the left. So this is actually due to retrograde transsynaptic degeneration from the cortex, from the brain, all the way down the optic nerve to the ganglion cell. This next case is a patient with multiple sclerosis. This patient has a history of optic neuritis in the past and has bilateral temporal disc pallor. The fields are fine bilaterally, but the OCT of the optic nerve and of the ganglion cell layer of the macula shows significant thinning despite unremarkable fields. Now, so with multiple sclerosis, patients can get optic neuropathy and optic nerve thinning with or without a history of optic neuritis. This next patient here was referred to us from her optometrist, by optometrist, because of incidental finding of an abnormal RNFL on OCT. So fields are fine. The right disc OCT was fine, but the left OCT shows nerve thinning over here. And the ganglion cell layer corroborates that thinning as well. So this is the ganglion cell layer analysis. Right side's normal. Left side shows significant thinning. And on further questioning, this patient says, I've actually got meningitis when I was younger and had papilledema. And so this, her nerve and ganglion cell thinning is a result of past papilledema. Next case, a 33-year-old female presented with headache. OCT shows some thinning of the disc, shows some thinning. The question is this optic neuropathy? So we did fields are fine. OCT of the nerve, of the disc shows possible thinning, shows significant thinning on the right and borderline thinning on the left, a couple of segments that show significant thinning. Now, her discs are small at 1.3 millimeters in diameter. So we said, so we thought, okay, could this be the reason why the nerve, the disc OCT shows thinning, artifactual thinning? But when you look at, so we went to the ganglion cell layer and had a look, and it was normal. So we were reassured that there's actually no optic neuropathy. The OCT of the disc looks thin, artificially thin, because her discs are small. So that's another use for the ganglion cell layer. Okay, moving away from ganglion cell layer, let's look at other layers in the macula. So my next tip is myopic foveus, which happens in higher myopes. The other term for this is myopic tractional maculopathy. Now, if you see these patients, you want to refer them for consideration of VR surgery, vitrectomy surgery, when there is subretinal fluid developing. You don't want to wait until a macular hole has appeared, because that macular hole would be difficult to treat, especially in high myopes. They are quite difficult to close. My next tip with myopes is that they often have a lot of macular pathology, and it's easy to miss choroidal neovascularization. So in this example, you've got patients with significant ERM that's distorting the anatomy of the macula. But in addition, the patient actually has choroidal neovascularization there. So it's important to watch out and look for choroidal neovascularization, which might actually be the cause of the recent change in symptoms, rather than the other significant pathology or more distracting, obvious pathology in the macula. Another example is this patient who had reduced vision. This patient's got a big posterior staphyloma, peripapillary atrophy, tilted disc, and OCT shows macular detachment due to a macular hole right there. Now, I mean, that's pretty significant pathology, and that needs to be fixed. But if you scroll through the other cuts or B scans of the macula in the cube, you'll actually see this, which is choroidal neovascularization. So be aware, look through all your B scan cuts if you did a cube of scans, because CNV in myopic eyes can be easily missed if there's associated other pathology. My next tip in myopic eyes is that the choroid is thinner in myopes, and we know that central serous retinopathy usually occurs in patients with thicker choroid. So therefore, CSR is actually uncommon in high myopes. So for example, this is on the right or on the left. You have this patient with who is a high myope and thin choroid. You can just see the choroidal layer just there. There's this darkish layer, lots of vessels in it. That's the choroid, and it's pretty thin. On the right, you have a low myope with conversely a very thickened choroid, and this patient has active CSR leakage. You can see some subretinal fluid here, that black puddle of fluid under the retina. So if you're making a diagnosis of CSR in a high myope, then think again. Now, there's this curious condition called dome-shaped macula, and as a compensatory mechanism, the macula can actually, in a high myope, which normally there's staphyloma and posterior bulging of the sclera, but in some sort of compensatory way, some of these patients actually develop a dome-shaped macula bulging inwards, like so. And these dome-shaped macula can often be associated with some subretinal fluid, which can fluctuate. So there's subretinal fluid there, and 3 months later it fluctuates and it's almost gone. And it can wax and wane, and it can masquerade as choroidal neovascularization. And a lot of these patients would have been, some of these patients would have been injected with anti-VEGF thinking there's a CNV there. And then they bring them back in a month and the fluid actually comes down, and you think, oh, okay, this is CNV and it's responding. Give another injection. Next time you see them, the fluid increases. So if the fluid doesn't behave the way it should in your patient that you think has a CNV, think of this condition, dome-shaped macula, and think think if the patient actually needs injections. My last tip is that we've talked about use of OCT on the nerve, use of OCT of the macula, but you can also use the OCT in the peripheral retina. So in the situation would be, if you look in the periphery and you've got a retinal elevation and you're not sure, is this retinoschisis, is this retinal detachment? So what you do is you get the patient to look eccentrically in the direction of the elevation and try to do a scan across the edge of the elevation. So if this on the left side here, left side scan, you can see this OCT catching the edge of this retinoschisis. You can tell it's retinoschisis because there is an outer layer of retina and an inner layer of retina with some lines connecting the two. So that's schisis. Whereas on the right side picture, the full thickness of the retina is lifted off, hence a retinal detachment.